Welcome to the Physicians Health Network, sponsored by OBHealthy. I'm Dr. Omar Bey, the host, and we're so happy that you'll be able to join us today. Let me just state that we're a group of African-American physicians that are here for two reasons. Number one is we're here to improve the health of people that are of African descent. Number two is that we are here to encourage young Black males to go into medicine. It is a crisis that is yet to be seen if we cannot change the dynamic of Black males and get them to go into medicine. Welcome. And we have a great webinar scheduled for you today. Our topic will be several topics, but we're going to start off with talking about Omicron because it's something that's in the African-American community, it's throughout the world, and we all need to know more about it so that we can stay healthy. Understand this webinar is every second Saturday at 1 o'clock, and I trust that you will continue to join us and tell others about it so that we can grow this audience, all righty? The past webinars can be viewed on YouTube. And hold on a second. And all you have to do is go to YouTube, go to OBHealthy, and you can view all of our past webinars and all of the topics that we've covered. Please subscribe to the YouTube channel such that we can continue to give our webinars to that company, and you can continue to view them. All right. Right now, I'd like to introduce the physicians who are with us at this point, and we will have other physicians joining as the YouTube video and webinar continues. We're going to start with Dr. James Lee. Can you introduce yourself, Dr. Lee?
Yeah, thank you, Dr. Bey. So glad to be here. Dr. James Lee Jr. I'm a board-certified orthopedic surgeon. I serve as the head team physician for East Orange Campus Football, as well as Bloomfield College, and I serve the Essex County and Greater New York area.
All right, thank you very much. Dr. Kendall Sprott, please.
I'm Kenny Sprott. I'm a board-certified pediatrician. I am retired. I did 15 years of critical care pediatrics and general pediatrics.
All right, thank you. Dr. Fredericks, Dwayne Fredericks.
Hey, how you doing? Good afternoon. I'm Dr. Dwayne Fredericks from Bariatric Surgeons, and I actually practice obesity medicine, and I practice in South Orange, New Jersey.
All right. Dr. Patrick Anderson.
Thanks for having me, Dr. Bey. Welcome to the crew. I'm Dr. Patrick Anderson. I'm a board-certified obstetrician gynecologist. I'm also chief of gynecologic oncology, board-certified in gynecologic oncology. Chief at Newark Beth Israel Medical Center with an office in Newark Beth Israel and in South Orange. Glad to be here.
All righty. And Dr. Aluya just came on. You're muted, Dr. Aluya. Please introduce yourself, right? Perfect timing.
Thank you so much.
Dr. Aluya, can you pull up the volume just a little bit?
Okay, let me see.
Just a wee bit.
Yeah, can you guys hear me?
Yeah, we can hear you. Yes, we can.
All right. So Nelson Aluya. I call myself a medical advocate, assistant professor of medicine, Rutgers University, New Jersey Medical School, an attending physician at Newark Beth Israel Medical Center. And always a pleasure to be here amongst these great minds.
Well, thank you very much. And Dr. Kevin Clark.
Hi, good afternoon, Dr. Kevin Clark. I'm a surgical oncologist at Newark Beth Israel. It's a privilege and a pleasure to work with these gentlemen.
All righty. So the most important thing that I can say today, no matter what we say as physicians and what topic we cover, do not change any aspect of your medical care until you consult your physician. Only your physician can truly know how to care for you appropriately from a medical standpoint. Also, I would like to thank OBHealthy for allowing us to to use their platform to bring this webinar to you. OBHealthy is a health and wellness, nutrition, as well as a weight loss company that specifically gear their wellness programs towards people of color and those that are medically underserved. So go to their website and download their app. The app is for free. And yes, it's something that I think we should all take advantage of, number one. I'd like to start off with in talking about Omicron, because this is something that's really grabbing the world right now. And Dr. Lee, I know that you are the physician for some of the schools in the area. And how do we protect our children? How do we deal with sports and Omicron as far as our children are concerned? Can you give us some idea of what you have to deal with every day?
Sure. I don't think there's an easy answer. I deal with two aspects of our community athletes, both on the college level and on the high school level. So I'm the team physician for East Orange Campus Football. It's a Group 5 school, predominantly African-American school. They happened to be undefeated this year and they won the state championship. So we had many games at many locations. And so I work with the athletic director, superintendent of schools, as well as the athletic trainer. And our goal is prevention. So what we encouraged our athletes to do is be vaccinated, wear masks when they can. And on the sideline, the coaches, the superintendent, the staff wore masks. And, our goal was prevention. Now, if you get on the football field, it's difficult not to transmit sweat and bodily fluids. It's just the nature of a contact sport where there's contact, heavy sweating, breathing. So our goal was to screen the athletes, check on them on a regular basis. There's weekly practices, and the athletic trainer and myself contact each other to update the status of the athletes and do our best to prevent a spread. One of my fears last year when I chose not to be a sideline physician was that you could have a football game be a super spreader event, and suddenly you've spread to grandma, the cousins, uncles in the community when you've had, say, a team come from, the suburbs or wherever, and they come into, our town, exchange germs, and suddenly it's spread all over. And so pre-vaccine, it was very concerning. And as many of you know, that there's a lot of pressure for our athletes to be on the field. There's scholarships at stake. There's community engagement. And so they want to see their athletes play. The parents want their sons and daughters to play. And so it was very careful. We're very careful with sideline behavior, post-game behavior, and then during the week screening, whether it would be for fever, malaise, or anything that would affect the athlete. Now, on the college level, at Bloomfield College, it's a little bit different in the fact that there's dormitories involved now. You have students who are on campus, and I serve on the board. And during the peak of COVID, we had quite a few students who were positive, and they were quarantined into special dormitories. Food was delivered to them. A lot of these students are from out of town, and they had to stay in separate quarters. So it's difficult. And then you're dealing with college students that want to socialize, right? And so you're on a college campus, and yet you can't socialize, party, interact, go to class. Very difficult. And it's one where there was some pushback naturally from students, but the idea was to quarantine, separate, and hopefully isolate the virus, and so it does not spread. So to answer your question, not an easy answer, but the best is screening and then intervention when we have positive cases.
Omar, if I might ask a question for Dr. Sprott and Dr. Lee, with respect to eligibility to enter classes, many institutions requires a vaccination series, a series of vaccination, H flu, meningitis. Is the coronavirus vaccine, with respect to full vaccination, including the booster, do you believe that should be a requirement?
Kenny, you're still muted.
Yeah. I'm unmuted now.
Yes, you are muted. Thank you.
Yeah, I've always been a proponent of vaccines, primarily because I came up in my training when there were a limited number of vaccines. And we had a number of both bacteria and viral infections that cause death in children and significant mortality. Over time, we developed more and more vaccines and pretty much were extremely successful. I remember in my training, we would sometimes have 30 pediatric admissions a night from respiratory diseases, meningitis, diarrhea. And with the development of these vaccines, we've virtually eliminated most of that so that very often a lot of the pediatric hospital beds have disappeared. A large number of hospitals don't even have pediatric floors, and the pediatric admissions are primarily centralized in some of the larger hospitals or special children's hospitals. And a good number of those admissions are related to chronic diseases like asthma or sickle cell or cancer. And that's a good thing. And so one of the major causes of death in very young children was influenza. And we developed vaccines for influenza, and it's recommended that children get those vaccines. And very much, it has to be appreciated that with influenza, most of the deaths associated with influenza were in the very young and the very old. And so a little over a year ago when COVID came around, it was fortunate, I thought, that very few children were being significantly affected by it. Certainly they were getting COVID, but they weren't being hospitalized. They weren't being admitted to critical care units on respirators. Very, very few. There were some outliers in terms of patients that had some different kinds of symptoms, something like Kawasaki's, which is a sort of a inflammation of a lot of the blood vessels. But because children play such an important component in the spread of the disease, both influenza and other respiratory kinds of infections, I thought it was very, very important that once vaccines were developed, that children were able to get them. And as you know, most people that died initially were elderly. And then as the elderly started to get vaccinated, the hospitalization and the deaths started to occur in younger adults. And once this past year ended in 2021, the vaccine became widely available. And for the past 6 months or so, almost all of the hospitalizations have been due to people that have been unvaccinated, or some of the individuals that have been vaccinated that really have difficulty responding to the vaccine, either because they have problems with their immune system or they're taking medications that might affect their immune system. Those individuals don't have the kind of protection that individuals that have normal immune systems have. And so some of those individuals have been hospitalized, and some have died. The one important thing that I think, and there's a lot of confusion about what the vaccines are designed to do or not. And the real bad thing about COVID were the number of deaths. And, we were over 800,000 individuals that have died from COVID in the United States. But these vaccines were not designed to prevent infection. They were designed to prevent people from dying and getting hospitalized. And so these vaccines were developed with only a piece of the virus that was designed, and that piece was the part that caused the virus or allowed the virus to attach and get into cells. Viral infections, they can't replicate outside of cells. So it's important that they have to get into cells and they attach. So the spikes on these pictures, 3D pictures that you see of the COVID, or how they attach to the cells. And that's what the vaccines were designed against, the spike protein. And so a lot of people who have gotten the vaccine have become infected with the virus. And that infection has been a mild infection. And so most of the people that have been vaccinated who get COVID will test positive for COVID. but they don't get very sick. And almost all don't get sick enough to get hospitalized or get on the respirator or get in. And so some of the commentators talk about there being breakthrough infections. And that's sort of a misnomer or bad terminology, because the vaccine wasn't designed to prevent you from getting infected. It was designed to prevent you from getting very, very sick. So what you're seeing now with Omicron, and I think that this is, just kind of my belief, is that once people got vaccinated, they were anxious to get back to normal. And so a large number of individuals who got vaccinated started not to wear masks, not do the social distancing, and start to attend events where there were a large number of individuals. And the large number of individuals could include individuals that are not vaccinated and those that are. But again, if individuals have not been infected with the virus, with the COVID, then they're susceptible to getting infected, vaccinated or not. If you're vaccinated, you don't get very sick. If you're unvaccinated, you might not get very sick, but you could get very sick. You could even die. And what we're now seeing is that as we've gotten a number of children who've been vaccinated and a lot of kids returning to school, because remember, during the first year, a lot of folks didn't attend school. Now you have a lot of kids attending school, some of whom were vaccinated, some of whom were not. But now you're attending school, and now in the wintertime where kids are in close contact, there's going to be a lot more spread, and that's what we're seeing. It's predicted that Omicron is going to continue to have these high numbers of infections probably through February. But again, the individuals, especially children, have not been very, very sick. Some kids are sick enough to get admitted to the hospital. We still don't have a large number of kids that are dying, and that's sort of a good thing. With influenza, we had a large number of kids that got sick and died. Some of them got sick and didn't die. But again, we're seeing with those individuals that have been vaccinated, they can get admitted, but very often a large number of those have not been vaccinated. Now, it's gone before the Supreme Court about, the mandate of workers to get vaccinated. And I don't see that, given how significant it is and how significant it is for kids to spread the vaccine, to spread the virus if they get infected, I think it's important that this kind of viral infection be considered no different than the other viral infections that are as contagious and it be mandated. And I don't think that there's any real harm to it. I think the thing that I think about is what's the difference between a actual viral infection that can damage the heart, damage the lungs, damage a whole lot of things versus the vaccine. Well, certainly you can have complications related to vaccines, but those are usually not so horrible. Complications from the actual infection are a lot more likely to happen than the vaccine. So my belief is that every child should get the vaccine if they can. And again, some of the questions are whether or not they might have a reaction to it or a severe reaction. But I would say that I would have no problem with it being mandated. I certainly think that there are exceptions to everything, but there needs to be a good reason for you not to get it. And I think that this virus will continue to evolve as long as it's out there. So, Delta's almost gone. Omicron is here. 3 more months, it might be something other than Omicron. But ideally, as people talk about herd immunity, in order for herd immunity or the stop of the spread from people actually getting it, you need to get almost 90% of the vulnerable population to have been infected. Now, about a week ago, only 15% of the United States had actually been infected. Almost 80% had been vaccinated. Only 15% has actually been infected. That means that 85% of the population could still get COVID. And that's what we're seeing. A large number of people getting COVID, but not so many people being admitted to the hospital. And so, and unfortunately, I have both my grandkids had COVID and my daughter had COVID. Fortunately, my daughter was vaccinated. My grandson was too young to get vaccinated. Now that he's got it, and my granddaughter, who's only 6 months now, Certainly, she had sort of, both of them had mild disease. And I think that at a certain point, they may get vaccinated and they should have super immunity, having had COVID and then getting vaccinated.
I want to make a point. Yeah, Dr. Sprott. Yeah, I'd like to say something too. With regard to being infected with Omicron or the coronavirus, not having been vaccinated, and then having some level of immunity, do you think that is a passport or a pass for, young people, a young population to say, listen, I had coronavirus, these are my T cells, I have antibodies? Would you say that population should be vaccinated and be mandated to be vaccinated if they've already had an infection and their body shows an immune response?
So the answer is it's unknown, and I'll just tell you what's said. And one of the issues related to that, as well as individuals who got the vaccine and then they were suggested that they get the booster. And for me, I think that if you had the vaccine, you got infected, had mild disease, and then got a booster, I'm not so sure that if you got COVID after having the vaccine, you need a booster. Because, what happens when you get the vaccine is your white cells, some of your white cells, get primed, and they have what's called memory. And so they're sitting around your body, all throughout your body. And if you then get infected and COVID comes around, they have a huge response. The army is ready, prepared, and they're out, and they come out and they hit that. So if you got the vaccine and then you got infected and you had that kind of response, I'm not sure you need a booster. As a matter of fact, I think there's a higher probability if you get the booster that you might have side effects, because you're hitting the immune system that's not only been primed, but it's already been activated because of it. The issue with just having the virus itself is I don't think we know enough about it. And the reason I say we don't know enough about it is one of the things that we're able to do is we're able to test the level of antibodies. These proteins or these attack dogs that go after the virus if it's seen. And what tends to happen is once you get your vaccine, those antibodies are up, they start to decline. The question is, do they decline enough such that you can get an infection even if you've gotten another infection? Don't know. And the question is, in my mind, is even if the antibodies are declining, does that mean that those white cells that have memory won't respond? Don't know. We do know with certain infections, and we don't know enough about this specific viral infection, RSV, respiratory syncytial virus. That's an infection that causes a lot of harm in very, very young children. And the problem with that virus is you don't develop significant immunity after you get infected. That means that you get the viral infection, you get antibodies against it, it goes down, and you can get RSV in another couple of months or another year. So what we don't know is if you have a coronavirus infection, whether or not over time, the antibodies or the immunity that you get are going to last a long time, or how long they will last. Remember, it's only been 1.5 years ago since the virus showed up. So I would say that, and this is what, I know the drug companies are happy, is yes, the recommendation is if you have a viral infection, we don't know that it's going to give you enough protection to last for a lifetime or last for a few years or not. And so it's better to get a boost, if you will, by having the infection. If you have the infection, you get the vaccine. I think the issue is the question, what about the reverse? If you get the vaccine, do you need to get a booster? And I say, well, yes, you should get a booster. But if you get the vaccine and you get the viral infection, I'm not so sure that you need a booster. The drug companies and a lot of folks are going to be overprotective and say, yes, you should get the booster. I'm not so sure.
All right.
My sister was one of those individuals.
But can we
had the infection?
We have to be certain to say that research has to pan that out. I understand that's an anecdotal, and that's your opinion, and I respect your opinion. That's 110% because you probably have more experiences than most of us. Dr. Aluya, I know that you were recently on a webinar talking about Omicron, and you know some of the questions from a pediatric standpoint, and Dr. Sprock had touched on some of these things. I know so many parents out there are so afraid to send their kids to school and whether they should or shouldn't. Can you give us some idea as far as where we should go as far as parents? Because we all have either grandchildren or children. Tell us what you think about that.
Well, thank you. Again, Omicron, the COVID vaccine is new, and that's why initially they call it the novel. We're still learning, but we're drawing inferences from what we have done before in the past from other diseases. We've had smallpox, chickenpox, measles, all the other ones that we've had, polio. And we're trying to draw inferences from them as much as we can to apply some of the new technologies that we have and compare them to modern day, needs and facts and apply them to a point where we'll be able to save lives and save livelihoods. And in approaching this, and that's where the dynamics and the politics, come into play from time to time. Drawing an inference from Dr. James Lee, there's no one clear answer. And saying everybody should go back to school. Yes, the sure fact is this: that school is still the safest place for any child, any day, any time. However, if we must ask people and to send their kids to school, there have to be measures and parameters that has to be taking place, and which area and where, what locality and what social or economic strata that can be put in place. On an overall base, it is best that every child goes to school physically, because not just that the disease itself and the risk and the fear of causing death and spreading the disease to the family, there's emotional, intellectual, and psychological affectation of children being home. And these things affect them, and not just for today, but for the long run, 10, 20, 30 years from now. And that's one. Two, the effect on the home and the character itself. I mean, I'm sorry to say, a lot of homes, especially in the inner city, poorly, low income area, they're not very equipped to handle the issues that take place in the home environment. And we know that with COVID, we've had an increased amount of risk of, child abuse, neglect, and, even sexual abuse, as a matter of fact. So again, and then a lot of our kids, especially for low income, Black and brown children, are children who basically get most of their meals from school. So putting that into perspective, for those in inner city centers, the ideal and the best thing is for them to go to school, period. However, those who are at the helms of affairs need to make it conducive, safe, and adequately well ventilated for these kids to be there. They have to take steps. One, ensure that there's adequate amount of social distancing. Two, the kids and the teachers are wearing masks. Three, there's great aeration or ventilation in those schools. Four, you can actually break the student population into two, in the sense that you provide some who will do homeschooling for those who really want to do homeschooling and can attain homeschooling, and those who want to do in-house, you have to. So it actually separates or reduce the number of children in classes. That's one. Or at the same time, you can actually how do you call it? Put them in shift. So certain kids will come in, certain days, and others will come in other days. And those are the steps, especially for inner city, communities. However, in upper class or upper class level areas where they can afford a whole lot of staying at home or doing, yes, they have to sit down and come to terms on how best to do this. But again, like we said, the best thing for every child is to be in school.
Omar, can you read the second question? I think it's very relevant to what we're talking about right now. It's very confusing to the public what's being said and what's being promoted. And there's a very, I don't think we did a very good job on educating the public on something that we don't even have a very good understanding of, and how we approach things when things are not fully known. Because a lot of what we're doing and a lot of what we do in medicine and science is there are things that we know and things that we don't know. And we have to still make a decision based on things that we don't know, but we can't anticipate. And I think we've done a terrible job at translating some of that to the public. If you read the question, or I can read it actually if you want.
You know what we're going to do, Kevin? I'll read the question. It's question number 2 that came in.
Yeah.
All right. First, what I'd like to do is I'd like to go back and allow Dr. James Court to introduce himself, because some of our physicians came in.
Good evening, audience, or good day, audience. I'm Dr. James Court. I practice in East Orange, New Jersey. My specialty is internal medicine.
Recording in progress.
Dr. Garrison, there we go. Excellent, excellent. Dr. Salam, please introduce yourself.
Yes, good afternoon, everyone. Merry New Year. Delighted to be with these brothers and to be with the audience. My name is Dr. Kareem Salam, and I practice in Philadelphia. I'm a board certified adult and child and adolescent psychiatrist. Before I pass the mic, I just really like to commend my colleague, Dr. Nelson Aluya. He talked about some of the social and emotional consequences of young people not attending school. And again, I couldn't agree with him more. School to young people is the equivalent of work to adults. So that's where a lot of social and emotional learning takes place. But just to reiterate, it has to be done safely. For many folks who are facing socioeconomic challenges, they receive at least 2 meals a day from school, breakfast and lunch. It's a place, it's a setting or a forum where interpersonal interactions take place. And also we've seen in the era of COVID, even some really, really strong students who are just not adapting well to virtual learning, and kids are tuning out. And they're being left with social and emotional deficits in addition to academic ones. So if kids could attend school safely, it should absolutely be done so. And finally, the Surgeon General of the United States made an advisory really discussing the state of mental health among children in this country in the setting of COVID. And it's actually an emergency. And being on the front lines, I'm seeing kids, armies of kids who did not have mental health issues pre-COVID, who are overwhelming the system because our kids are just really struggling mightily to adapt to this current situation. So again, Dr. Salam here, and I'm delighted to be here, and Merry New Year, everyone.
Thank you, thank you. Dr. Jordan Garrison, please introduce yourself.
Good afternoon. My name is Jordan Garrison. I'm a general and vascular surgery. I specialize in disease of the venous system, varicose veins, et cetera, along those lines. It is an honor to be among this group of physicians who, know a lot more than me. I have vascular surgery that I know a whole heck of a lot about, but the issues that you guys are talking about, I need clarification for myself, my family, and my patients. So, I'm going to do a lot of listening today, and hopefully you can clarify these issues, not only for the public, but for me too. So as we go forth, that the ideas and the thoughts that we come up with here will be spread for the interest of the public. And I'm looking forward to a good seminar.
Thank you. Dr. Kevin Clark, let's get back to you as far as excuse me. Oh, Dr. Court, was there something? I'm sorry.
Yes, I came a little late, unfortunately, but I listened to Dr. Sprout, and one thing that bothers me in terms of what he said to the audience is that with the vaccine, we're introducing a piece of the virus. I'm faced with that all the time, that patients tell me, well, they put in the virus into me. I think we should be very careful in terms of what we put out there. It's not actually a piece of the virus. It's a few of the proteins that comprise the virus. It's probably a technical term, but I want to see what the audience, what the members of the panel think. What should we really tell the patient? A piece of the virus or just portions of the proteins that make up the virus?
Yeah.
I don't even think you need to get that specific. Again,
Dr. Court,
the question comes all the time. Well, you put in the virus into us.
well, the proteins are part of the virus.
Yeah, but
it's
kind of. I know.
And technically,
yeah.
the virus is really thought not to be alive. So I don't want to get too technical about it, but yeah. So our proteins, our cells make proteins. They're part of us. But anyway, I just wanted to just talk a little bit about what actually happens in terms of how we get infected. And in order to get infected, you have to be exposed to a certain amount of the virus, if you will. And depending upon how much you're exposed to might influence how sick you get. But in essence, when you first get exposed to the virus, the virus has to enter in the cells, it starts to replicate, and then your body recognizes it, and then your body starts to react to it. So before your body starts to react to it and the cells start to replicate, you may not have any symptoms. So in most cases, and again, most cases, it takes about 5 days from when you get exposed to the infection to when you start to develop symptoms. Some people might develop a little bit earlier, some people might develop a little bit late, but in general, it's 5 days when you start to have symptoms. And those symptoms tend to be related to your respiratory tract in general. So it's a respiratory virus. It affects the cells that line your respiratory tract. And then you start to have symptoms. You might have runny nose, you might have cough, you might have this. And as your body starts to attack, you may start to have fever. You start to become able to infect other people actually before you start to have symptoms. So you get exposed, maybe about 2 to 3 days, you can actually start to infect someone, and then you have symptoms. So sometimes, you say, well, if the person starts to have symptoms, then they should isolate. Well, if you could predict that you're going to have symptoms, you would isolate a little bit earlier. And that's why when people would say, if you know that you're exposed to someone, you need to start to isolate. Now, what then happens? Well, once you start to have symptoms, your body, your immune system starts to ramp up. And as it starts to ramp up, if you were actually to measure the viral count in your body, it would still be starting to go up. Maybe about 9 days after you got the infection, 4 to 5 days after you got the first symptoms, your body, and most folks, starts to take care of that viral infection, and the numbers start to fall. So the number of viral particles, if you say, in your body start to fall. And so maybe a week or so after you've gotten your first symptoms, the level starts to fall far enough so that you become less able to infect other individuals because your counts start to go down. And that's why people used to say, well, once you got infected, 14 days, you don't even have to get tested, you shouldn't be infected. And maybe a few days even before that, you don't become able to get infected. And so that's sort of the way that almost all infections happen. You get infected, you don't have symptoms initially, you develop symptoms, you might have fever, your body starts to respond, and that's how most viral infections, cold, flu, everything else, it's a 10 to 14 days and you're done. Some folks will continue to go on and be sick, even without COVID. Some folks go on and be sick for a much longer period of time. Some of it related to that inflammatory response that damages your lungs. Doesn't mean that those individuals are infectious, because they may not even have the virus present at all, not recognized, and they still are sick. So this issue of the question is, they said, okay, well, if someone has the vaccine, gets sick, they can wait 5 days. Well, there was no real science around that. They just said, and again, I think the person was right. It may be related to practicality, but I don't think that we know enough. There's a natural belief that if someone has actually have vaccinated, since they are not so symptomatic, some of them are asymptomatic, maybe the amount of virus that they're releasing from their body is small, but no one actually can take those counts. Most of these studies are not being done, so we don't actually know. And so I think that the individuals who are vaccinated, who get COVID, maybe they're not able to spread the virus. I don't think there's enough science around it after 5 days. Maybe after 10 days, yes. The ideal thing would be, and again, most folks aren't doing it, some folks are, is to test to see whether or not they still have viral particles after 5 days or so. Some folks don't even want to get the test, and so they say, well, just give a certain amount of time, 5 days, 10 days, whatever it is. Again, there's no science about the 5 or the 10 days, but we do believe that those individuals who are less symptomatic are less likely to be as infectious, but no one is doing any studies to determine that.
You know, Omar, I think the answer to this question
Hold on,
is
Patrick, just for a
in the question.
I'm going to let everybody answer, get a chance to ask their questions and answer questions. Let's just try to keep it a little not so technical, number one, and let's try to keep our answers up just a little bit short because there's so much more I want to cover that if we, you know what I mean? So Patrick, go ahead.
No, I was saying that, the answer to the question is intrinsic in the question, right?
Mm-hmm.
It's a combination of what's practical and the science. Let's look at the two extremes. Let's say we didn't know anything, we didn't have any science. And I know my colleagues are infectious. What do? I stay away from them. I isolate myself. And then I ask them to isolate themselves. Now, when do we come out of isolation? We don't know because we don't have the science. So it's a combination of being practical and what we do know. And then there's the pressures from society, right? We need staff to run our healthcare facilities. We need drivers to deliver our supplies to our doors, right? Our economy has changed drastically over the last few years, right? We used to get up, get dressed, go to the restaurants. Now you have the restaurants coming to your front porch, right? We don't have people to deliver what we order. So there are pressures from all sides. So it's a combination of what we know as science and what's practical, all right? And then bear in mind, the whole concept of vaccine is not new. So and if you look at the history of vaccines, where we actually used to use attenuated live viruses, then we went to attenuated viruses, then we went to portions of the viruses, then we went to the molecular aspect, where we're taking, the DNA, we're making mRNA from it, and then making a copy that's equivalent to what's in the virus without even touching the virus, right? So this whole concept, the science has evolved over time, and it's a matter of combining what's practical with the science to give us the best outcome. And no one should go out there and say, this is the perfect outcome, because like Dr. Sprague said, we just don't know enough. And may I say, while we're worried about COVID and Omicron, and it's utilizing all of the oxygen in the room, there are other virally related diseases that we've been using to protect people for years. This month, might I add, is Cervical Cancer Awareness Month. Cervical cancer is an infectious disease caused by the human papillomavirus. And we've had vaccines against HPV for the better part of 20 years now. We've gone from having a vaccine to the 4 most virulent type to now against 9 virulent types, given starting at age 9, and you can give it up to age 45. And we've seen where the incidence of cervical cancer is at least been reduced by 50%. And while I say cervical cancer, it's not the only HPV-related cancer. There are anal cancers, penile cancers, cancers of the oropharynx, all of which benefit from the vaccine. So it boggles my mind that folks will say, I don't want to get cancer, and probably will be quick to get that vaccine, but is not quick to get a newer vaccine that has killed way more people in a year than cervical cancer will have killed in a year. We have about 14,000, 15,000 new cases of cervical cancer every year, of which we lose maybe 4,500 patients. We've lost way more than that to COVID. So it's a matter of being practical and looking at the acuteness and the acuity of the situation that we're dealing with. All we're asking is people to make reasonable decisions.
Well, if I may add to everything else, people do study. There's a whole lot of study, and with regards to the 5 days of you isolating and all that, invariably we knew, and I knew we were gonna get there, because again, it's balancing saving lives and livelihood. Because again, as we begin to save more lives for the vaccines, thank God the vaccine came out, we need to learn to save livelihoods. We can't continue to shut everything down every day, every time. Now, some of the studies that actually came out says that 38% of individuals will still shed the virus 5 days after. So 38% will shed the virus 5 days after. Now, the question is this: how much would they shed that would infect somebody that can cause that? So, and that's the reason why, again, the government like, okay, stay home 5 days. And besides, for those of us who are in the healthcare industry, we cannot afford to have everybody sit at home 10 days on and on and on again, because then the healthcare system is overwhelmed. 1, 2 doctors, 3 doctors, nurses go down, that's it. So, but 10 days after, about 13% of individuals will still shed the virus. So, but how much of them would be, shed enough to infect somebody else? That's where some of the issues are coming up from. So I think a big play here will be where we have platforms like this, but then we have individuals who would connect with either organizations and the government, where we'll sit down and have a concrete, definite, objective talks with the science, the play on the ground, and those who are in government, so that we come up with rational, achievable, sustainable, answers to our problems.
Excellent, excellent. Dr. Clark, we're going to get back to you with this second question. I know that, and this is the second question that you had brought up earlier. It states, who is dying from Omicron? About 90% of the patients that are dying are unvaccinated. That's the question that you were referring to, Doctor?
No, well, it was one of the questions from the attendees, and some of it is addressed. It was bringing up the issue of how do we mix science and practicality, and in terms of the recommendations, because things seem to be a little bit confusing, and it's what's based on data and what's not based on data. And I think we answered it, in the sense that we don't have all the information, but you make your best judgment based on what you have. It's not going to be based on individuals, and that's one of the things we have to understand. It's a population-based recommendation, and anytime you do population-based recommendations, you look at what the minimum effect or how much you have to do to get the most effect. So it may not be relevant to everybody, but at least it will address most of the patients in a beneficial way. And I think that's what probably is confusing to a lot of people, as Dr. Sprott pointed out. You probably, and again, I don't want to make any recommendations or not make any recommendations, but the recommendation for the booster is a broad-based recommendation, but probably not everybody needs it. And I think it's hard to tease out who doesn't need it. And it's probably, I won't say easier, but if you're going to make a population-based recommendation, the rationale for recommended across the board, you can see that.
All righty. I understand. And now I see that question, and I'm sorry about that. I had went the wrong direction there for a second. Dr. Salam, there was a
question that came through that's talking about, and this I truly feel is something important in our community, talking about grief and the issues about grief in our communities for many reasons. But the fact that patients that come into the hospital that are critically ill and those family members cannot visit those patients and have, and if unfortunately that patient dies, they can't, really connect with their family members as they pass on. Can you tell us about something as far as grief in our community and how we should try to deal with it in the age of Omicron in this pandemic?
Sure. Excellent question. Particularly in the setting of a disease, of a pandemic, where we've lost over 800,000 people in this country, and under just really strenuous circumstances where folks aren't able to say goodbye. So, number one, most of us do not want to die. So step one, we should do everything to mitigate the risk of severe illness, death, medical complications. So I think we could unanimously advocate for getting the vaccine so you could avoid or mitigate the risk of these end-of-life situations. Sadly enough, we will encounter them. So it's important in the setting of COVID to really value each other, use our time wisely. I remember pretty early on during the pandemic when I noticed the way this was heading, I wanted to publicly encourage folks to, any beef or conflict that you're having with your loved ones, it's really time for a perspective shift and really weigh the importance of those conflicts in the setting of a global pandemic. So we have today, we're safe, healthy, well, and alive today. Let's take full advantage of today. So we should prioritize these relationships so we don't have regrets. One of the most tragic losses of my life was actually a colleague that I was developing a close relationship with, who happened to be a frat brother of mine and a co-author of mine on many of the books we worked on. And watching this person transition really caused me to reflect on my own mortality. And in the service of positive thinking and not being mindful of the data and the risks associated with their condition, I never took the opportunity to say goodbye. And so I don't want anyone to share that regret. And COVID has made this really difficult because of the infectious nature of the disease, and Omicron has a level of virulence it's just not commonly seen. We're fortunate in that the disease that's caused by Omicron tends not to be as severe as the previous variants, and the symptoms are, they seem to be more confined to the upper respiratory tract. But we want to value these relationships. We want to do everything we can to live and avoid those grieving situations. Finally, grief involves vulnerability. And our history in this country and throughout the world, we've been encouraged to be strong and to appear strong. But there's some things that are out of our control that could affect our health. And they cause us worry, and they cause us anxiety. And we don't want to have these worries and anxieties pent up inside of us. So it's important to have relationships where we could share these struggles and share these burdens. And when things reach a point that they interfere with your ability to function and carry out your daily tasks, that's an indicator where you need help. So again, sharing your vulnerability, particularly with those you have a relationship with, is a sign of strength, despite our history, despite the challenges we've overcome as a people. But if we want to keep going, being vulnerable is an important part of that, so we have an opportunity to release these burdens And these psychological burdens could affect you at the cellular level. So those are my thoughts on that.
There's another aspect of Omicron, that's the blood clotting. We really feel that COVID, there may be very small blood vessel as well as larger blood vessel clotting that may be a part of this this disease. Dr. Garrison, can you give us some indication and some I should say some guidance as far as blood clots? I know from my perspective as a pulmonologist, one thing that I worry about all the time is a pulmonary embolus. And I could explain that in more detail if need be, but can you give us some ideas as far as vascular system or our vessels and clots and how that can affect our livelihood, you know, just to survive? Give us an idea.
Yeah, there are two entities that we have to worry about. One is superficial thrombophlebitis, or the veins that are underneath the skin when they clot off. This is usually a self-limited process and can be treated with anti-inflammatories, warm compresses, and it goes away. It may take a little while to go away, but it does go away. It does not pose a great threat to causing what is known as pulmonary embolism, where a clot will go up to the lungs and cause problems with your respiratory and cardiac system. That is caused by clots in the deep veins of your legs, in the central veins of the legs. So as surgeons, we're always concerned about this when we do manipulations, especially in orthopedic surgery, and even in other forms of surgery, that you have to get the patient up and mobilized. There's something called Virchow's triad, which is composed of three different things. And one is stasis, or slow blood moving, two, hypercoagulability, or thickened blood, and the third is trauma to the blood vessels. Hypercoagulability can be caused by diseases of the blood system, but most commonly it's caused by not hydrating enough. You know, it talks about between 32 and 64 ounces of non-flavored or clear liquids, non-protein based liquids a day. So that's water, seltzer, whatever your flavor or drink may be, but you should hydrate. Most of us do not drink enough water every day. So that would cause the blood to stay pretty thin. The other thing is stasis. What are the types of things that cause the blood to flow slowly? Well, the most common thing that we can do to prevent the blood from flowing slowly is exercise. And it doesn't have to be running a marathon or riding a bike or anything like that, but simply getting up and walking. That's one of the common things we do after surgery, is have a patient walk. We get them out of bed. It gets the blood flowing. It also gets the lungs pumping. And so that is the easiest thing we can do, is just walk. Now we're talking about hydration. And endothelial injury is, you know, preventing trauma to the blood vessels. Do not putting things in our blood system that can cause irritation to the blood vessels. Those are substances, legal and illegal, that we should not be using. So I think the best prevention is, one, make sure you're hydrated. Two is walking. And three is limit the toxins that we put in our system. And at this point in time, most people who are over 20 years old know what the toxins are that they could be putting into their system, legal and illegal.
Right. You know, the thing of it is that in the ICU, when patients come in and they're very sick from COVID, and we're still, as Dr. Sprock has stated, we're still learning about this disease. And there are many aspects of the disease that we don't fully understand, and we're trying to treat the best we can. When patients come in, one of the things, one of the diseases or entities that we are fearful of is blood clotting. And blood clotting in a situation where it's what we call a pulmonary embolus. This is blood clots that would form in the vessels that are leading from the right side of the heart into the lung. And these are the vessels that allow us to as we state, oxygenate our blood. And that means that the oxygen that comes in when we take an inhalation, the oxygen that comes into the lung tissue is diffused or goes across the membrane in the lung. It goes from the lung into the bloodstream and then attaches to the red blood cells, which carries oxygen to the rest of the body. These blood clots actually inhibit the blood flow through these vessels such that we do not get oxygen into our bodies appropriately. And we become, as we called it, hypoxic or low oxygen in the blood system, which affects every cell in the body. So when these patients come into the ICU, the first thing we do is start on a COVID regimen, but we start them with a medication called heparin, which is a blood thinner to help prevent these clots from occurring. And it's one thing that we've noticed, and heparin has helped immensely. We still don't know 100% why, associated with COVID, you do get the pulmonary embolus or clots in other areas like the deep veins that Dr. Garrison had talked about. But there are many patients that have long-lasting effects of shortness of breath and trouble breathing after having that severe COVID because of the clots that occurred in the lung. And even with the treatment during the acute phase, they continue to need treatments of blood thinners for many, many months post-therapy or post-hospitalization. All righty. At this particular point, what I'd like to do is take a moment, a break, our halftime break, and just introduce each of our physicians one more time, because there may have been folks that have joined that did not get a chance to hear our introduction at first. Dr. Lee, can you start off, please?
Yes, hi, Dr. James Lee Jr., orthopedic surgeon practicing Essex County area.
All righty. Dr. Sprott, you're on mute.
I'm Kenny Sprott. I'm board certified pediatrician. I did 15 years of pediatric critical care and about another 20 years of general pediatrics.
All right, thank you very much. Dr. Aluya, you're on mute as well.
Yes, Nelson Aluya, a medical advocate, internal medicine, pediatrics. Thank you.
All righty. Dr. Court, I think Dr. Court is reading, but we'll go to Dr. Salam.
My name is Dr. Kareem Salam, board certified adult and child and adolescent psychiatrist, practice in Philadelphia. Earlier, we were talking about grief, and I belong to a group of Black psychiatrists who publish mental health literature. And our most recent book is Bree's Journey to Joy, a story about childhood grief and depression, where we talk about a young lady who lost her Nana to COVID. And it has a parent guide. It's a children's book and a parent guide written in question and answer format, highlighting topics related to grief and depression. And we're very focused on the African-American community.
Oh, thank you very much. Definitely a book worth getting. Yes, it's on Amazon, right?
It's available on Amazon. Bree's Journey to Joy, a story about childhood grief and depression, published by a Black-owned company that I'm a founding member of, and we focus on the mental health issues in the African-American community, completely owned and controlled by us.
Oh, thank you. I'm so happy about that. So happy about that. Dr. Garrison.
Once again, good afternoon. My name is Jordan Garrison, board certified general vascular surgeon, practice in Hackensack, New Jersey. I specialize in the disease of veins and the arteries, and it's just a pleasure to be here. Thank you.
Right. Dr. Kevin Clark, please.
Good afternoon, Dr. Kevin Clark. I'm a surgical oncologist. I practice at Newark, Beth Israel.
All righty. And Dr. Patrick Anderson.
Good afternoon. I'm Patrick Anderson. I'm a board certified GYN oncologist. And like Dr. Clark, I practice at Newark Beth Israel Medical Center.
All right, thank you. And understand that every second Saturday, we are here. The African American and Black physicians are here. We would like to answer your medical questions. We will get to some more of the questions on our second half. Understand that you can view our past videos on Zoom. Just go to OBHealthy, and that's on YouTube. And we would love for you to go there and just educate yourself on the past topics. I would like to thank OBHealthy for allowing us to bring this webinar to you. Understand that they have their app out that's health, nutrition, and weight loss. Just download OBHealthy app, put in the 365 and get it for free, please. It's definitely worth it. The last thing I would like to say is please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you appropriately. So don't change anything, no matter what we say. All right.
Dr. Bay, did you introduce yourself?
I sure didn't, and I always forget. Thank you, Kev. I'm Dr. Omar Bay. I'm pulmonary critical care and a subspecialty in nutrition. And I've been practicing for too many years. And that's why I still forget to introduce myself. All righty. So where we're going now is I'd like to take one of the questions. This question came in. It says, hello, I am a middle-aged female. Had an episode yesterday while I was walking. I got lightheaded and dizzy. Couldn't get my bearings for a while there. And she was worried that she may fall or pass out. 7 to 10 minutes later, hold on, let me read this, hold on. And I was worried I would fall. Oh, excuse me, it passed after 7 to 10 minutes. Could this have been a transient ischemic attack, which we call a TIA? Note that she has high cholesterol as well as blood pressure and does take her meds. Can we get one of the internal medicine docs to chime in on this, a TIA? Maybe we can explain what a TIA or a transient ischemic attack is, and if this is a possibility and some other possibilities that may have occurred to this young lady. Can we start off with Dr. Aluya and then go to Dr. Court and see if we can get an answer with this?
Yes, TIA, like the word said, transient, meaning it lasts only for a certain, amount of time. Usually it resolves within 24 hours, and that's the essence. And it can occur from a temporal occlusion or blockage of the blood flow to a particular area of the brain. What are the risk factors? High blood pressure, high cholesterol, diabetes, obesity, and all of them, even some medications as well. So what's the incidence of that? Very high. I can't remember if there's any numbers, that's been pushed attached to it, because a whole lot of them, happen and they go unreported. I just have a little side aches and pain, or I pass out for a minute, go to the hospital. Nope, I'm not going, I'm fine. A weakness can happen and then it's fine. And it can happen in the elderly, more in the elderly than in younger people with those, chronic medical problems. And they tend to resolve with no residual effects, meaning your arm is not, completely gone or weak. You don't lose control or ability to speak or walk or any of those things. It really, really resolves. It can be from just a small, minute clot that just went into a particular area. It can actually also come from spasm of certain vessels where they close up completely. And maybe that's the reason why, those things happen. And some of the other things that can happen outside of that are those with people who are migraines. And sometimes some people don't see that, they don't know that. There's what they call complicated migraines. People with severe migraines that eventually go on to give them, some form of lateralizing signs. What does that mean? Meaning they have one side of the body like a stroke that's completely weak, and they come to the hospital. They do an MRI, CT scan. There's nothing. But if you take a good history, you find out that they have migraines, and then it resolves it with itself. Those people tend to have a whole lot of emotional stress as well. So if you dive deep and ask those questions, you'll be able to tease them all out, and it's easy. You can handle that.
All righty.
I have a quick question. Dr. Aluya, could a TIA, a transient ischemic attack, could that be a harbinger of a potentially worse event to come?
Yes.
Yes, it can be. Like I said, for those who have diabetes, high blood pressure, and all that, it could just be what you call a prodrome, or it could be early signs or a warning, to say, be careful, take steps to handle your business. Otherwise, something more serious is on its way.
What do you mean by more serious? You mean strokes or?
Correct. Stroke,
yeah.
heart attacks,
Sure.
and all of those. Because one of the things people tend to forget, and I'll tell you this, especially for those who smoke. Now, we talk about peripheral vascular disease. A young guy came to meet me in the office on Thursday, and he left another doctor, and I said, why? A brother. He, like, why did you leave? Oh, because I just feel I wasn't getting as much as I needed to get. And I've been complaining, and they just say, it's your weight, it's your weight. But I think it's not my weight, because when I walk, after a few 10 minutes, I have to stop. It hurts. I have tingling in my legs and all that. He just went on and on. He has diabetes. He has high blood pressure, controlled here and there. And I let him talk. And at the end, I said, do you smoke? He said, yes. So I said, how much? The first thing they always say that, I'm cutting back. If you ask someone, do you smoke? The next thing they'll say, I'm cutting back. No, it's not, if you're cutting back. And then the next question I had to ask is, again, how long have you smoked for? If you're 60 and you smoke for 20, 30 years, look, that's a cumulative effect of that smoking. The cumulative effect is so much more than when you were 20 and you're smoking 10 packs a day. So if you're 20 and smoking 2 packs a day, and you're 60 and you're smoking 2 cigarettes or 3 cigarettes a day, it's almost equivalent, because over the years, the cumulative effect is so much more. And the analogy I always tend to say is this: if you put a bucket here and put 1 drop every morning, in 3 months, the bucket will fill up. It's not the amount that you put in, it's the cumulative effect of the 1 drop over time. So people tend to forget, again, peripheral vascular disease, meaning those, blockage and narrowing of the vessels of the leg, is a harbinger, is a prodrome, is a pointer to very, very severe issues of narrowing of the blood flow in the brain, in the heart, and in the kidneys. So if you begin to see that, please get them to check your heart, check your brain, and check your kidneys, because those are very early signs that are coming, or something bad is about to happen.
All right, so what I want to know for this particular question, what should she do next? I mean, obviously she had some significant and serious symptoms there that happened. We can't really diagnose it for her, but there are other things it could have been. It could have been a heart arrhythmia, abnormal heartbeat. It could have been, some other things that could have caused this as well. What should she do next?
Well, the most important step for her to do is go see her doctor. That's one. Straight up, go see your doctor, have a one-to-one talk with your doctor, and tell them what happened to you. But before you go, you have to get prepared. I always say this: you have to get prepared. Every time you go see your doctor, one, you write down all the medications you're taking, either the one the doctor gave you, or you had been ER, a month, 2 months, somebody else added another medication. Write everything down, and you can write down the signs and symptoms that you got. Because sometimes if you're sitting down, when you do that, you remember stuff better than when you're sitting in front of the doctor. People tend to forget. So write everything down, get prepared, and get a list of the questions that you need to ask, because sometimes the doctor may forget as well. So when you have that sit down talk with your doctor, and then they'll be able to review your blood pressure, check your sugar, and then in the office probably do an EKG or even an ABI to check the blood flow blockages to your legs. And then the doctor will be able to sit down, review with you the steps to take to mitigate what you have. So if you have blood pressure, you need to take your meds and make sure you're taking the meds. If you have diabetes, you have to do all of those. So all those steps. And then of course, you have a follow-up visit with that same doctor. If they tell you come back in a week, you go back. Not like, oh, I'm fine now, 6 months, a year later before you show up.
Right. So number one, and I'm concerned about this. I truly feel that number one, she should call her doctor right away. Don't hesitate as far as this is concerned. Number one. Number two, and if by chance you have any feeling like this again, go straight to the emergency room. Do not stop, go straight to the emergency room and be evaluated at that moment. Do not let this happen again and not go to the emergency room.
I absolutely agree.
All righty. Yes, definitely. And thank you for that question. I mean, this is so important, and I'm so glad that you posed this question. All righty. I'm sorry. Go ahead, Dr. Court.
I absolutely agree with you, because very often we are faced with this. Patient will come to me saying, oh, a week ago, I passed out, but the EMS came and they said, oh, they examined me and I'm okay. If you pass out or you have a near syncopal episode, the time to go to the emergency room is on that day, because then you can pick up what could have happened on that day. To come to see the doctor a week or so later, you would miss a whole lot of stuff. In addition, you go to the emergency room, the two main things that would operate in my mind would be heart or brain. These things can be looked at right there and then on that day, rather than 2 or 3 weeks later, because patients come to doctors, you send them to a neurologist, they may not get an appointment for another 2 or 3 weeks or even longer. The same applies to a cardiologist. So the emphasis should be the patient should be examined the same day, rather than 2 or 3 days later.
And just a quick vocabulary lesson. Dr. Court mentioned a near syncopal episode. So syncope means passing out. And frequently it's of cardiac or heart-related origin. And near syncopal or pre-syncopal, you feel as if you're about to pass out, as if passing out is imminent, but you don't. So, unfortunately, there's so much fancy vocabulary in medicine that could be used to kind of erect barriers between us and the folks we're trying to help. So any opportunity to break that down, we'd love to.
All right, thank you, thank you. There's another question that came up. I'm gonna read it here. I heard about the new variant identified in France that has 46 mutations. Any new information on whether these mutations are causing the virus to be even more virulent or contagious? Does anyone, I've heard of the variant. I haven't heard much more than that it exists. Not that it's outside of France, I'm not sure, but has anyone heard more about it or could give us more detail?
Yeah, so I did talk about it at the last Zoom meeting I had. It's actually called the IHU. IHU out of, it's called the Infectious Hospital of University in France, south of France, because that's where it was first identified. Yes, 46 mutations and about 32 deletions on the
Dr. Aluya, can you bring up your volume a little bit, or can you come closer to your computer?
Yeah, so I said it was first identified in south of France, in the International Infectious University Hospital, and that's why it's called the IHU. And they said they picked it up from an individual who had been to Cameroon and came back home from Cameroon to south of France. It has 46 mutations and 32 deletions on the nucleosides, meaning those components that form the protein that form, the virus itself. Now, what do those mutations mean? Just like the Omicron, when it came out, had total of about 50 mutations, and on the spike alone had about 32. Now, they still will continue to review that. In their mind, they think those mutations may be more a reason for it to be more virulent or may be more infectious. We don't know that yet. But as at the time, I think this week, as a matter of fact, 12 individuals were identified in France. And then they're still
Nelson,
trying
could you
to
just
review.
elaborate on what you mean by virulence?
However, they had said that it may not be that new, because November 7th, when they went back to review some of the samples that were taken before November 7th, they actually identified a few of the components of the IHU strand. So we may not know that yet, but we're still learning. We'll know more.
Could you tell us what you mean?
Go ahead, Dr. Sprott. Go ahead.
We've mentioned virulence a couple of times. Could you explain what that means?
Oh, okay. Meaning the ability to cause more disease, to infect the person and cause more disease and make them really, really sick. One of the things, and I said this before, that viruses, as like human beings, the only thing they really want to do is propagate, period. They want to pass their DNA down to their generations, just like we do. We want to pass our DNA down to our generation and preserve our species. So we have been able to change our environment by regulating temperature, regulating airflow, regulating everything around us, so that we can propagate our species by passing our DNA from one generation to generation. Viruses and bugs, they cannot change their environment. So what do? They change their DNA to do that. So when they do cause the DNA to do that, the change in their DNA can cause three things. One, they make you really, really very sick so that they can infect you and then reproduce more of their DNA and pass out. Two, escape your immune system and everything else that you brought around to kill them, meaning your vaccines, to escape your vaccines. And three, have the ability to transmit or infect somebody else. So those three steps are some of the things that viruses or other bugs tend to do so that they can propagate. So every time we hear this, mutations will always happen. And again, they tend to do that by two means. There's what they call antigenic shift and an antigenic drift, where they shift a short, small component of the DNA so that they can escape, do those three things I talked about, or form a whole component of their DNA, drift it completely so that they can do that. So that's what they do, and it's part of nature. What do we say? We just have to live with them, fight with them, accept them, adapt, and move on.
All righty. There, we have some great questions going on here. Let me get one more. If a 3- and 4-year-old had the virus, should we look for any effects that may have had that it may have had on that child? Can we talk about this? I know, Dr. Sprock, you had your grandchildren, which are young, have had the virus, and you had spoken about that earlier. This person wants to know, should they expect or look for side effects or effects of that virus on the kids?
My short answer would be no, but that would be oversimplification. I think that for the most part, we know that the disease has been fairly mild in individuals. My grandson had no symptoms. My granddaughter had cold symptoms, and although we know that since the virus can get into different parts of the body, it can cause damage. I don't think that anyone is predicting that that's going to be an issue unless a child has some symptoms. And most of the kids that have colds or influenza or anything else, they recover fully afterwards, and we don't really look for things because we don't know exactly what the virus may or may not have done. As a matter of fact, if something does come up, there would be really not any direct way to determine whether or not it was due to the virus or whether or not it would happen from something else. So no, I think that you should expect that the 3 or the 4-year-old should recover without any kind of signs or symptoms. But if the child were to have something, you'd bring it to the doctor, and then the doctor would make a decision about whether or not the child need to be referred to look for something. But I don't think, you know, you go looking that, oh, we're going to do some follow-up test on the heart or the brain or the kidney after they had COVID.
Oh, all righty, all righty. There's, and Dr. Salam, this may come into your realm a little bit here, and as well as Dr. Aluya. There's a question about substance abuse and mental health as far as the African American community is concerned. And it's something that we've been troubled with for many years, but I think it's even more apparent now with the pandemic. It's coming out and being noticed more. And how do we address this in the communities that we serve? Can we start off with you, Dr. Salam? And maybe others, I just don't want to key on you because this is such a broad topic. I think that we all kind of interact as far as this is concerned, and we can all kind of chime in. Dr. Salam, can you start us off with this?
Oh, sure, absolutely. This does not apply to all cases of substance abuse or substance misuse, but it certainly accounts for many of them. There tends to be more stigma associated with mental illness than a substance use problem. Moreover, and I think Dr. Garrison mentioned, he talked about substances. He very eloquently stated those legal and those not legal. And those that are legal, like alcohol and nicotine, and in some places cannabis, they're associated with less stigma, but they were more commonly known as gateway substances. So in the meaning they could, if they get out of hand, they could lead to the use of more potent substances and substances that have higher potential for addiction. And the way that works is you develop tolerance. What does that mean? So if you're let's say you're smoking weed, not medical marijuana, and you want to achieve a certain high, if you keep smoking the same amount, you will not achieve that high and you'll have to smoke more. And then you reach a point where you're investing so much time and energy in smoking so much weed for the same high that you have to move on to a substance that's more potent. And in the setting of a global pandemic, we have more disposable time. So we have more time on our hands. Sometimes we're more bored, and you know, so we have alcohol laying around the home, so we might use that. We have more access and time to smoke weed, so we may use that. And then that could lead to other problems, because what these substances tend to do is they disinhibit us. What does that mean? Affects the part of your brain that rests behind your skull, your frontal lobe, which serves as your set of brakes. So you're upset at someone, you're having an argument with a family member. In your head, you might want to strike them, but it's your frontal lobes that says that's not a good idea, I shouldn't do that. When you disable that set of brakes, that frontal lobe, you may act on these lower impulses under the influence of substances. So that's why substances could be particularly detrimental. Add to that, someone with an underlying mental health condition, whether it be anxiety, whether it be depression or something else, you have the concept of self-medicating. So folks would say, if I'm taking an antidepressant, that must be because I'm crazy. But if I'm taking a drink, then I'm good. If I'm puffing an L or smoking a joint or hitting a spliff or blowing a tree, then I'm, you know, hey, there's nothing wrong with that. At least I'm not crazy, okay? So the beauty of the era we live in now is that we're having these conversations about mental health, and we're giving folks permission to not be well and to seek treatment. And we're, you know, there are organizations like the one I belong to where we're really trying to attack stigma so folks could get help in a better way than turning to substances and creating new problems in their lives.
I'd like to raise an issue because, and again, Dr. Garrison talked about legal and illegal. You know, as far as I'm concerned, all of these substances that are being abused are chemicals. Some are synthetic, some are natural. But you know, this year there were over 100,000 overdoses due to synthetic opioids. Primarily fentanyl is one of them. Fentanyl is a prescription drug. Actually, cocaine is a prescription drug. ENT uses it. But you know, we talk about drugs that are legal versus illegal, but the body doesn't care one way or another. And you know, there's such a significant amount of death associated with fentanyl, primarily because it's used sort of as an adjuvant, if you will, something that's added to other things like heroin. So there's a mixture of fentanyl and heroin to increase the dose, and it kills. And we spend a tremendous amount of money trying to restrict the use of drugs, prosecute, arrest, incarcerate, and there's a dearth, as far as I'm concerned, of treatment centers for those individuals that abuse these substances and want to get treatment. And certainly a large number are incarcerated, and a disproportionate number of them happen to be people of color. And you know, I think that we don't talk about it very much, but I think that there's some inherent value in looking at the possibility of legalizing some of these substances and trying to devote more of the dollars that are currently used in law enforcement and incarceration for treatment. And we probably wouldn't have some of the problems or the crimes associated with the illegal use of some of these things. Marijuana, which had been illegal, is now legal in most things. So I think this issue is something that needs to be thought about, and looking at how much time, energy, and money is being wasted on something that for the most part could be better handled if things were more legalized.
Yeah, you know, the one aspect that I think about when I think about mental health in our communities, and you know, that obviously segues on to the substance abuses. Why in our communities is it so difficult to talk about? You know, why is it such a stigma for us as opposed to other cultures? And how can we as physicians truly effectively get the word out there that it's okay to say, you know, I may need some help, or I have this problem. And it's not the worst thing in the world. It's, you know, people aren't going to look at you like you have two heads. There is true help out there. Can you help me out as far as that's concerned?
You know, I alluded to some of this earlier, just given our history of struggle and what we've gone through as a people, strength has always been valued. And so seeking help for mental health involves a certain amount of vulnerability. And I think messaging is important. And I think an ambassadorship is important. So just like we have this webinar the second Saturday of every month. So when people see us, they see their relatives, they see their friends, they see people who look like them, who have an investment in them because we are them and we're of them. So I think the situation will be better now than it was before, and that it should continue to advance. But representation matters. So people want to hear these messages from folks who are knowledgeable and who look like them and who've had shared experiences with them. I think that could attack stigma. And the organization I belong to, Global Health Psychiatry, that's the bet that we made. We said there aren't any better ambassadors for Black mental health than us. And we're going to go out there and prove it by publishing this literature and going where the people are. We're not staying in grand rounds. We, pre-COVID, we were going to churches, to mosques. We were going to street festivals, right? And the beauty of Zoom is now we've expanded our reach. So we've democratized the message. So I think we've made more inroads in this short amount of time than we have, many years prior.
Yeah, I think.
I just like to say that mental health issues are extremely common. Depression is extremely common, and so many people are depressed and are either not diagnosed or inadequately diagnosed. And then a lot of the treatments that are available have complications associated with them. And although, my brother, Dr. Kareem, talks about psychiatry, the ability of individuals to get to see a psychiatrist, especially a psychiatrist of color, is extremely difficult. And so, you have a large number of African-American folks who don't have the ability to access, really, psychologists or psychiatrists. I'll give you an example of a friend who has the best of insurance and needed to access a psychiatrist because of a tragedy that happened. Extremely difficult. So what about a psychologist? The number of psychologists, that I could call for a favor, they said, Kenny, I would love to help. I just can't. I have so many patients and they have been exacerbated by COVID and everything else. It's just extremely difficult. So I don't know how many people that know that they have problems and again, I look to the internists. I don't know how many, Dr. Court and Dr. Aluya, I know that you have to be seeing a ton of individuals that are depressed, and how comfortable you feel in putting them on medication, because the majority of psychiatrists today are just interested in pushing medications to make folks feel better without attempting to get at the dynamics. Psychologists can, but they're inundated. And so, there's a tremendous need. I'm not so sure that there's the personnel, even before COVID, but now with COVID, to address the needs of the population. And I know that you, Dr. Court and Dr. Luya, you could be writing lots of prescriptions for people that are depressed because the need is there. And very often, I dare say, and I can't say it, a lot of the African Americans that go to see white doctors probably don't even ask them about the questions that would lead to the diagnosis. So, you touch on something that I think is, very near and dear to me, because I think there's a tremendous need and not enough personnel or access to get these needs addressed.
Yeah. Patrick, the thing of it is that, and what I was going to ask is, I know how you and your patients are. You're like family to your patients. How do you, give me some indication on how you relate to things like this in your office?
So, I place myself squarely in the same environment that I see my patients. We loosely say come down to their level. I never want to say that because I never think I'm on a different level than the people in my community. I probably go to more funerals than I'd care to admit to, because when I start to take care of someone, and most of the people I take care of, they have chronic illnesses. Thank goodness we have treatment modalities that allow us to prolong their demise in many cases, and in many cases cure and can celebrate. And in every aspect, I'm part of the process. I go to college graduations of children of patients whose their first word to me was, I just want to be here long enough to see my little girl graduate from high school or from college. And oftentimes, play psychiatrist, practicing just basic medicine or a psychologist. And fortunately, I have a wife who is also a clinical psychologist who sometimes I can tap into, her experience. But I say this to say, unlike hypertension and diabetes, we don't have a hemoglobin A1C that tells us if someone is depressed. Sometimes you have to dig, and then the tears come out, right? Mm-hmm. Sometimes we don't have a 130/85 to say, oh, you're schizophrenic, until I carry on a conversation and realize that all the song and dance I'm doing, this person in front of me is really not engaged, right? So there's some ambiguity with respect to recognizing that there is a mental illness, or we ourselves recognizing that, I just had a moment of depression, right? I mean, I went through my own personal experience where, Dr. Court, Dr. Clark, I remember one time called Kevin up and said, Kevin, I just don't feel right. Meet me in the emergency room. I think he was on the golf course and he met me. And sure enough, I had an acute problem that more than the physical aspect of it was the mental component of it. Dr. Lee was reconstructing my shoulder and he said, brother, how do you feel? I said, listen, I know you can physically get me back functioning. The question is, my psyche right now is asking me, what if I can't operate again? That night before he fixed my shoulder, I think I was up all night. So the recognition, there's just so much ambiguity that goes into identifying mental illness globally, and then the specific mental issue that needs to be addressed. So for me, with my patient, I immerse, and Kevin does the same thing. Kevin and I meet and talk to these patients, more often than you think. I mean, when there are holidays, we personally go out and shop for meals for Thanksgiving, buy toys for Christmas, because it's the only thing we know. Now, I'm not a mental health professional, but I will never ever say that, because I feel like everything we do, every touch, every time I look a patient in the eye and say, look at me, I got you, okay? It helps them in some way deal with the stressor. Our issue is I don't have the skill set to identify the specifics and to make recommendation as to how to deal with the specifics.
So I want to point something out. What Dr. Anderson just did is powerful. Look at the most recent comment in the chat. So here it is. We're in a very, whether we agree or not, we're in a very privileged position as physicians in this country. And so,
Black position.
What'd you say?
I said black position.
Absolutely, absolutely. And so when the brother just shared, he was struggling, but he got help. Okay. And so if he can get help, we can all get help. And you know what? The world that we were born into, that we live in, and that will die and leave is imperfect. So no, we don't have the personnel right now. And in terms of prescriptions for the most commonly used antidepressants, selective serotonin reuptake inhibitors, SSRIs, those are largely written by primary care physicians, internists, pediatricians, and family practice docs. So, but again, we're moving forward. We're increasing awareness in our community. And one of the missions for Physicians Health Network is to inspire younger brothers to replace us so that the workforce will expand. So I'm very hopeful and optimistic, and I think we have good reason to be. And thank you, Dr. Anderson, for sharing your story and your truth and giving people permission to not be well.
Yeah. I'm sorry. Go ahead, Dr. Clark, because I wanted to ask Dr. Lee. You have a population, and Dr. Court, don't forget your question. Don't forget your question.
Okay.
You have a population of patients that you see that's an older population, and when you talk to them, you're usually doing surgery on this older population, and they know, and that sometimes the result may not be as you know what I mean, what you like it to be because of their age or because of the morbidities that they carry or the side illnesses that they carry. How do you relate that to these patients as far as coming together and getting them to understand that, you know, there's no perfect medicine, but this is what we need to do? And let's you know, pray to God that we get that good result.
Yeah, I think a good example is an elderly hip fracture, right? You have an elderly person in a hospital, you know, that may have a heart issue, diabetes, kidney disease, breaks their hip. I'll give you an example. I saw a 91-year-old lady with dementia a week ago on her way to her daycare, fell on the curb, broke her hip. And I think one of the first things I do is I call the family. And you know, it's a demented person. They may not be able to communicate. They may be only oriented to their name. I call the family right away. And I say, listen, you know, grandma, your auntie, she broke her hip. She's got these major issues with her heart, lungs, or whatever that may be the case. This is what I think. Now I say, you can rattle off statistics and say 10% of these people will die in a month and 30% die in a year. You can say these things, but do it in a manner that they understand. Just say, listen, 91 is 91. We cannot get around that. 91 plus 3 major conditions, that's putting us at risk. But you know what? Because grandma was walking, we want to try to get her to walk again. And you know, the best way to do that is with surgery. Now the surgery, before we do the surgery, grandma needs blood work done. She needs to be looked at by the anesthesiologist, by the medical doctor. Appropriate testing has to be done. And if she's a candidate, we're going to fix that hip. However, afterwards, it's a long road. And I think engaging the decision makers, if it's the patient for sure, but also the extended family, because in our community, you know, we have folks that are involved, hopefully involved, and you have to engage them and explain and try to hedge a little bit. Say, listen, this is what happens most of the time, but occasionally they die, or occasionally, you know, they get a clot, or occasionally they may not leave the hospital in 2 days. They might need further care that keeps them in the hospital, but know that we're watching it. We're going to do the best we can.
Yeah, I think, you know, I think part of the communication here is, you know, what Dr. Lee didn't say, but over and over he expresses, and, you know, it's personal, and that's compassion, right? The messaging is powerful. And someone may be astute enough to understand the statistics. You say it and they don't hear you because it's delivered with lack of compassion. But you can take grandma's hand and you can look her in the eye and you can always say, grandma, this is what it means. But if you, whatever decision you make, I'm still here.
True. Dr. Court, I don't want to forget you.
No, don't, please don't. I have a different perspective because I treat a population as 100% non-white. My problem in terms of psychiatry is that I cannot rely on my 3 months of psychiatry rotation at Howard University in 1979 to treat these patients. I have a problem finding Black doctors to see them. One, I think one of the major problems that the patients have is insurance. Psychiatrists, would they devote 1 hour and get paid $20 to evaluate my patient? So as a result, most of the people resort to using medication rather than psychotherapy. And as far as I know, in this area where I practice, I only know of 1 Black psychiatrist. And I think this is a field that I don't know what happened. I don't know what happened.
No, you're good, Dr. Court. We hear you.
Okay, well, that we can use some Black brothers to go into this field. And like part of our program is to encourage young Black men to go into medicine. And this would help tremendously. I don't know if Dr. Salam, if they have a program where in Philadelphia where they can treat patients who are quote unquote indigent, they have Medicaid, and to find a doctor to see them, it's almost impossible in this area, especially in the field of psychiatry.
So I have so the answer is yes, but typically different medical schools in Philadelphia are linked to clinics that serve the indigent, and it involves attendings who are mentors, medical students, and residents. These programs have been in effect even when I was in medical school. I graduated in 2000, and I did many of my rotations in Camden, New Jersey. And there was a program called Hip Hop, Homeless and Indigent Population Health Outreach Program. And that was back in the late 90s, early 2000s. And these programs have advanced. Now, they refer to the Black physician as the medical unicorn, and that take that a step further for the Black psychiatrist. But most people with mental health issues don't need psychotropic medication. And that said, most of them don't need a psychiatrist. So you have excellent mental health providers who don't have terminal degrees, master's level clinicians and therapists. So it's a matter of looking for these people, finding these people. And I constantly have people reaching out to me, Kareem, I need a Black psychiatrist. And typically they don't need a Black psychiatrist. They need a skilled professional that they would prefer to be Black to conduct therapy. And that's an easier find. So.
Dr. Kareem, thank you so much for saying that.
Dr. Aluya, yeah, and then Dr. Sprock. Go ahead, Dr. Aluya.
Yeah, thank you so much, Dr. Kareem, for saying that. As a matter of fact, like we all know, it's so difficult to find a psychiatrist anywhere, any day, anytime. And then to compound that, even Black psychiatrists you can't find. And to buttress what you said, a lot of the times they do not need that in-depth psychiatric help. It's just like sometimes, somebody comes in with an asthma, acute, reaction from an allergy reaction or even a headache that may just be stress-induced. You don't send them to a neurologist. You don't send them to see Dr. Bay, because it's asthma that can be managed. You can manage those things in the clinic. So also psychiatric or psychological issues that transcend on temporary, you can handle them just by sitting down with them. A few of the times, especially with COVID, what do? When they come like that, they complain, I sit down, we talk with them. And if there's a need to, give them a little bit of a booster, like an anxiolytic to help them, cope with the immediate issues they're having, I'll do that. And then get them to come up with a 1 week follow-up, a 2 weeks follow-up. And sometimes I grade them like that, a week, every week, and then every 2 weeks and every month, and they do well. And they never come back to see me. And the next time you see it, it's for their chronic medical issues. Now, when it comes to mental health issue is not an African-American thing where it's not discussed. It's a Black thing. And I think it's going way back home to Africa, it's even worse. It's not something nobody talks about. They don't. And maybe we inherited that and brought it all the way across the Atlantic to America, to Europe. Probably, maybe it's written down somewhere in our DNA, somewhat. But if I look back and see how mental health issues were addressed, there were steps to them. First is the family. The elders will come and sit down and address those issues. And then they tend to resolve that before they go on to, the traditional healer, who we had then as traditional healer. But by the time the Westerners came, they called them voodoo doctors. And the whole thing, was just thrown apart, and it was bastardized, and they became almost like spiritualists. But then there were spiritual connotations in how they managed those mental illness, the severe ones, even back then. And unfortunately, that aspect was not allowed to evolve like Western medicine evolved. So like every issue with the Black man, our advancement, psychological, mentally, physically, intellectually, was truncated deliberately at a certain time with such intent. So we were not allowed to evolve like we should. So, and these are some of the issues that form a conundrum into issues and problems that we're having today.
Oh, excellent. Dr. Sproul.
Yeah, I just, want to echo a little bit about what Dr. Court said in terms of, I think we have a perfect storm, in terms of this issue of access to care. As he said, insurance. Even folks with good insurance, a lot of psychiatrists will only accept cash, or the best of insurance is to pay the most amount of money. And today, most of the folks that are graduating from medical school, going into residencies, when they finish, they work for either hospitals or large multi-specialty group practices. And there, the doctors are on the clock. I hate to say it, but they have a limited amount of time that they can spend seeing a patient. And then when you get to referring, who are you going to refer to? Look, I practiced in Newark for most of my career. And so it was mostly Medicaid population. I saw a lot of my mothers, primarily mothers, that were depressed. I knew that they were depressed. I can't treat them. Who can I refer them to? No psychiatrist, no psychologist. And the way that a lot of folks can get treated is psychiatric social workers, that's increasing, and there's some Black folks that are there, but everyone's inundated. And so the question is, how do you get folks to get the help that they need? And no, I don't think that they necessarily need psychiatrists or necessarily need medication. Some do. Some of it is situational. But given where we are today, I think this is a problem that's growing, and there's a significant issue of access, especially if you're poor.
Yeah. What I would like to say is, throughout the country, there are health centers called they're federally qualified health centers. And usually just about every large city will have a federally qualified health center. They may be different names in different areas. Here, the largest one in Essex County is Newark Community Health Center, which services several cities around Newark and Newark itself. There are seven centers, and they really have pediatrics, they have internal medicine, OBGYN, they have dental, they have psychiatry, they have infectious disease.
Recently, psychiatry.
Yeah, recently. And they're trying to expand that. So, the thing of it is that these health centers—
Dr. Sprott, you got to make room for progress, brother. We have to start somewhere. Come on, brother. I'm sorry, Dr. Bay.
I want progress too. It just looks like we're going in the wrong direction with mental health.
Right. Well, we're trying to turn this around, and our focus, number one.
Omar,
our focus. Go ahead, Kenny.
You look at what physicians go into. Mm-hmm. Not a whole lot of folks are going into psychiatry because they don't make a whole lot of money, and you hate to say that, but it's the truth.
Right. True. But one thing, what we're doing at this particular point with this webinar is letting our people know exactly what we as physicians feel and how we feel that we can come together and try to let the world know how they can help us move things forward as far as improving health for our community. So it's so important that we come and talk about it and share our, from a physician's perspective, from a Black physician's perspective, how do we deal with the population that comes into our office? How do we deal with our patients? How are we going to deal with the future? And who's going to take care of us when we get old? So these are some questions that we have, and there's no perfect answer, but we're going to do the best we can to come together to see if we can solve this problem, because the problem is only becoming larger as time goes on.
Omar, if I can make a statement, there are some parallels here that we need to pay attention to. If you take law enforcement, for example, many people say the reason our communities are policed the way they are is because many law enforcement personnel do not have a real connection with the community. Mm-hmm. I mean, I was one of those people who, as proud to say, I came up in a system where many of the people on this panel has been committed and devoted to not just serving the population, but educating the population. I'm a product of such endeavors. Dr. Spratt was my attending. He taught me. You were my attending. You taught me. Dr. Court was. You taught me. And I think that's what we're seeking. We're seeking a few good men at a time that we can mentor. I think one of the struggles we have, and it highlights the value of some of these FQHCs, the federally qualified health centers, is many of the people who run these clinics are people who are from the community and they're invested in the community.
Mm-hmm.
And oftentimes they collaborate with the major health care networks. So for example, I know I take care of a lot of the cancer patients. I know our department take care of a lot of the high risk obstetrics. But part of the problem that we encounter is there are many providers who are really not connected to the community. They come in at 9 and they leave at 4:30. And God, and the community be damned with respect to what happens between 4:30 and 9 a.m. the next day, right? And I think we need that level of commitment, just the way it's argued for areas such as law enforcement. We need people who are of the community, from the community, committed to the community, just the way I'm sitting here saying, I'm a product of some of you guys on this panel.
Mm-hmm. Yeah, I agree 100%, Patrick. Yeah, I agree. I think oh yeah, you're still with us. All righty. This has been an awesome discussion. And let me tell you, I think we need to have more discussions like this towards the end of our webinars, because it's important that the public understands that, we're people just like they are. And we have, fears and anxiety and all the things that they feel, we feel. And we're trying to do the best we can to pull our community together and service this community in the best, at the highest medical level that we can, because it's so important to all of us. And I know, because I talk to all of y'all, that when our patients come into our office, that they know 110% we're going to do the best we can. We're going to get them the latest treatment, the best treatment, to do what we can to make sure that they continue to be healthy throughout their lives, so that they can become grandmothers and grandfathers and you know what I mean, and live a long, healthy life. And that's our goal. So I just appreciate each and every one of you coming and truly telling us your experience, and we connecting together like this, because it's so important that the public know how we feel about them, and how important it is to us that they do well as far as medical care is concerned in delivering that. So as usual, we've come to another end of another show. Listen, I'm just so happy that each and every one of you come and join and express yourselves as you do, because there is so much knowledge on this webinar. And I'm going to pull every inch out of you every month that I can, because I want to know it all. And if I want to know it and you tell me, then the public knows it as well. And that's what it's all about, educating our people. So let me end with this. Thank you, each and every one of you, for being with me here today and bestowing your knowledge. I would like to thank OBHealthy for allowing us to bring this webinar to you. And please download the app, go to OBHealthy, download it to your phone, put 365 in and get it for free. It has webinars, it has meal plans, it has recipes, it has all kinds of good stuff, health webinars of all types of problems, medical problems, that just is put together for African Americans and people of color. All right, number one. Number two, please do not change any aspect of your medical care until you consult your physician. Only your doctor can truly take care of you. And until we meet each other again, I'm going to say peace to each and every one of you. And we will see you in February. Peace, everyone. All righty. Thank you very much. Goodbye, everyone.